Hello, am I audible to all?
Yes, sir.
Yeah. Okay. We shall start the class. Today's class is all about revision. We'll briefly discuss about important topics asked in the exam regarding the general surgery topic. So in general surgery, like first we'll discuss about salivary glands and thyroid. Then we'll go for wounds and ulcer. Then the last topic we'll discuss about trauma and shock. So first we shall discuss about salivary glands and thyroid. So briefly, I'll tell you about what are important topics in salivary glands. So salivary glands, basically they are divided into major and minor salivary glands. Major salivary glands composed of parotid gland, submandibular gland, and sublingual gland. Minor salivary glands are 800, approximately 800 in number, and located all over the oral cavity. So the most common tumor. So if they ask you in exam the most common tumor of salivary glands, your answer should be pleomorphic adenoma. The most common tumor of salivary glands, the answer should be pleomorphic adenoma. The same question, if it is asked as the most common tumor of salivary glands in children, so it changes to hemangioma. Just remember, see the majority of the salivary gland tumors arises from the major salivary glands. That too, in major salivary glands, most of the tumors arise from parotid gland. So if they ask you the most common, it should be pleomorphic adenoma arising from the parotid. So if the same question, if they ask you like in children, so it should be hemangioma. So pleomorphic adenoma. So let's discuss in detail about pleomorphic adenoma. Pleomorphic adenoma usually arises from the parotid. It can also arise from submandibular and sublingual, but most common site being parotid gland. So coming to the anatomy of the parotid, we'll just discuss about the anatomy of the parotid. Parotid has two lobes, superficial lobe and deep lobe. This superficial lobe and the deep lobe are divided by the facio-venous plane of Patty, and this is also a question. Superficial lobe constitutes 80% of the parotid gland, whereas deep lobe constitutes 20%. Superficial lobe and the deep lobe are divided by the facio-venous plane of Patty. This facio-venous plane of Patty from superficial to the deep. From superficial is facial nerve. Facial nerve has 5 branches. So in the bed of the parotid, the facial nerve trunk divides into 5 branches, characteristically called as pes anserinus. This pes anserinus is nothing but the goose foot. The branches of the facial nerve resembles like a feet of a goose. So we call it as pes anserinus. So it has cervical. It has 5 branches totally: cervical branch, the cervical branch, the temporal branch. The superficial one is the superior one is temporal branch. Next, zygomatic branch. Next, third one is buccal branch. The buccal branch is again divided into upper buccal and the lower buccal. And the next one is marginal mandibular. Fifth branch is cervical. So this 5 branches of the facial nerve takes place in the bed of the parotid, called as pes anserinus. So the deep lobe, superficial lobe, the facial nerve, then followed by the retromandibular vein. So the retromandibular vein is nothing but it is found by the joining of the tributaries of superficial temporal vein from above, and maxillary vein transversely. These two joins to form retromandibular vein. It is found just deep to the facial nerve, and then next comes the superficial temporal artery. So these three constitutes the faciovenous plane of Patty, which divides parotid gland into superficial and deep. The pleomorphic adenoma is a benign tumor of the salivary glands, usually the most common site being the parotid. And in also in parotid, the most common site being the superficial lobe. So hence you just remember, hence if they ask you what the surgery recommended for pleomorphic adenoma is superficial parotidectomy. Just a minute, I'll just share you the pic. So this is the pleomorphic adenoma. So usually see by looking at the swelling, it is located in the see the NEET pattern has changed. Like everything, majority of the questions in surgery is coming on a clinical basis. So they are giving videos or they are giving photos or any procedures, and they are asking any instruments, and they are asking to mention the instruments. See, this is salivary gland tumor, pleomorphic adenoma arising from the parotid. See, it is located in the region of the parotid. So if they ask you, so the classical clinical signs here is, so there is an ear lift. So the tumor is located just inferior to the ear, lifting the ear lobule. Ear lift sign is a characteristic sign in tumors arising from the parotid. So ear lift sign here, it is clearly seen, ear lift sign, and it is located in the region of the parotid. So one more important clinical sign usually asked in the exams is curtain sign. So curtain sign is nothing but, so when you try to move the parotid, when you try to move the swelling horizontally and vertically, there is relatively restricted mobility in the vertical direction when compared to the horizontal direction. This is why, because this parotid swelling is, this parotid gland is enclosed in a deep cervical fascia. Though there are fascias in neck, pretracheal, prevertebral, investing layer. So deep cervical fascia encloses the investing layer, encloses the parotid gland, and the superior attachment of this investing layer is to the inferior border of the zygomatic bone. The zygomatic bone. So hence there will be restricted mobility in the vertical direction. Curtain sign, ma. Curtain. CURTAIN. Curtain sign. So there is restricted mobility in the vertical direction than the horizontal direction. It is a typical sign in parotid swellings. Two things, ear lift sign. So if they ask, if they put this question like photograph and ask what is it like, what is your diagnosis? So it can be like pleomorphic adenoma. So typical signs, one is ear lift sign, another is curtain sign. Curtain sign is nothing but related to the mobility. So this is arising from the superficial lobe. So one more thing, if examination of the oral cavity is mandatory in a parotid gland swelling, because the pleomorphic adenoma can arise from the deep lobe also. So if the swelling is arising from the deep lobe, we have to check for the tonsillar bed. So rather than presenting at the externally, it presents as an at the tonsillar bed. It has two lobes. It can isolatedly, it can occur at the deep lobe, or isolatedly it can occur at the superficial lobe, or both combined. So what is, if they ask, so this is pleomorphic adenoma arising from the parotid gland. So what is the investigation of choice? The next question is, what is the investigation of choice? So the investigation of choice for any salivary gland tumors or swellings is FNAC. Usually, if they ask you not, if they ask you non-invasive, always go for ultrasound.
क्या हो रहा है? वो नीचे बैठ तो वो नीचे बैठता फिर वो गिर जाती उसका दाई रोटी बाबू से एक हाथ से पकड़ के वो भी ऊपर बैठी खाए वो भी ऊपर बैठी खाए वो एक हाथ से खाते हैं.
Hello, am I audible to all?
Yes, sir.
Yeah. So this is a typical swelling arising from the parotid gland. So investigation of choice. So if they ask you non-invasive investigation, which is the best non-invasive investigation in parotid swellings? So it should be ultrasound. If they ask you the best investigation of choice for thyroid parotid swellings is FNAC. Just remember FNAC. FNAC should be there. So in histopathology, FNAC is nothing but fine needle aspiration cytology. You put a needle, you aspirate it, you check for cells. So in pleomorphic, as the name indicates, more than 2 morphological structures: epithelial component, mesothelial component, mesenchymal elements. So it is a combination of all these elements, multiple elements, pleomorphic. So it is diagnostic. So after FNAC, what will you do? You go for an surgery. So this is also very important question. So what surgery will you do for pleomorphic adenoma, parotid swelling? So it is superficial parotidectomy. So always remember it is superficial parotidectomy. And also the important question related to this: what is the incision you give for superficial parotidectomy? It is lazy S incision or cyst trunk incision. Just a minute. So this is the lazy S incision. See the incision extending from the in front of the tragus. Take a curvilinear incision going behind the ear and then going to the middle of the neck, junction between middle and lower part of the neck. So this is a typical lazy S incision or cyst trunk incision. And see, before going to the incision, there is an important topic regarding this. So how will you identify your facial nerve? So identification of facial nerve during parotid surgery is also an important question. There are two important named procedures. Like one is Conley's point or tragal point. Conley's point is nothing but, so 1 centimeter in front and 1 centimeter below the tragal point. Tragus, you have the tragus in the ear, no? So just 1 centimeter in front and 1 centimeter below the tragal point. You just go 1 centimeter in depth. See, all the thing you have to remember is 1 centimeter. 1 centimeter in front, 1 centimeter below, and 1 centimeter depth. So this is the point where you can identify the facial nerve trunk. So preservation of facial nerve is very important in parotid salivary gland tumor surgeries, superficial parotidectomies. So one technique is Conley's point, C-O-N-L-E-Y, Conley's point. The next point is Hamilton-Bailey technique. You all know about Bailey textbook. So it is Hamilton-Bailey technique. See, whenever, if there is already there previously surgery has been done for the parotid and recurrence has been seen. So you have to preserve the facial nerve. So you have to identify the facial nerve trunk. So Conley's point may not help you in identifying the identification of facial nerve. It is Conley's point, C-O-N-L-E-Y, Conley's point or tragal point. Conley's point is just in front and below the tragus of the ear. 1 centimeter in front and 1 centimeter below and 1 centimeter depth is the place where you can identify the facial nerve trunk. This is Conley's point. If in a previously operated case of parotid gland tumor, the Conley's point, repeat the incision names. Lazy S incision or cyst trunk, SISTRUNCK, cyst trunk. Lazy S or cyst trunk incision. So previously operated case of salivary gland tumors. So Conley's point cannot help in identifying the facial nerve. At this point, you can use Hamilton-Bailey. So as we all discussed, that facial nerve is divided into 5 branches. The one is cervical branch, temporal branch, zygomatic, upper buccal, and lower buccal. See, in this Hamilton-Bailey technique, you identify the distal branch. At the upper lip, you identify the distal branch and go retrograde to the tragus point. This facial nerve divides into 5 branches. The most consistent branch among these 5 branches is upper buccal. So you identify the upper buccal nerve and go retrograde. The Hamilton-Bailey technique is nothing but you go in a retrograde manner, fashion to identify the trunk of the facial nerve. One is Conley's point, other is Hamilton-Bailey technique. These are the two techniques where you identify the facial nerve. Why is it necessary to identify the facial nerve? If the facial nerve is not identified properly, or if there is any injury to the facial nerve, the patient can land up into facial nerve palsy, lower motor neuron facial nerve palsy. Please repeat in which case we don't use Conley's point. Conley's point can be used, but it does not favor in identifying the facial nerve in already previously done parotid surgeries. So there will be a scar in this line. So at the point where you at correctly the Conley's point, the scar will be present. So it will be difficult to identify the root trunk. So in that cases, rather than going into the Conley's point, you identify the distal branch. So upper buccal, just at the upper lip. You just identify the branch of upper buccal and then go retrogradely to identify the facial nerve trunk. Understood? So so the upper buccal nerve is the most consistent branch. So you go retrograde from the upper buccal and identify the facial nerve, and then you dissect off the superficial lobe of the parotid. So care should be taken not to injure the facial nerve. If the facial nerve is injured, the post-op the patient can land up into facial muscle palsies, facial muscle paralysis. So the patient can have deviation of the mouth, the patient can have ptosis, the patient can have decreased expressions, facial expressions. So facial expression is given by the facial muscles. Facial muscles is supplied by the facial nerve. So if you are going to injure the facial nerve, then there will be paralysis of the muscles. So that is the reason why you have to identify the facial nerve. And also for identification of the facial nerve, we have 2 points intraoperatively. One is Conley's point, other is Hamilton-Bailey technique. So after doing superficial, after you remove the parotid gland, so what are the complications of the superficial parotidectomy? This is also an important question. So any surgery, see, if they ask you any question in the surgery, what is most common complication of any surgery, any named surgery, it will be hemorrhage. So again, this is also very important for you. The hemorrhage is again divided into primary, reactionary, and secondary. The primary hemorrhage is the hemorrhage occurring during intra-op. So during surgery, if you have any hemorrhage, it is denoted as primary hemorrhage. What is reactionary hemorrhage? Reactionary hemorrhage occurring within 24 to 48 hours. This is also a question. Reactionary hemorrhage duration is 24 to 48 hours. Reactionary hemorrhage, what is cause? These are the two questions. One is, what is the duration? So within what time will reactionary hemorrhage occur? Within 24 to 48 hours. So what is the reason for reactionary hemorrhage? So it is due to the slipping of the ligages. Anesthesia. So if you're, this is a concept oriented question. So if you are going to, if you are doing a surgery, so it should be done under anesthesia. If the patient is given general anesthesia, there will be hypotension. The blood pressure of the patient will be low. So say around 100 or 90. So normal systolic pressure is 120 and diastolic is 80. So 120 by 80 is the normal blood pressure. During surgeries, it should be less than 100 or 90. So at this pressure, when you are identifying any vessel and tying it, so there will be no hemorrhage. So everything, the hemostasis will be secured. So immediately after the surgery, so the anesthesia gets weaned off. So the kidneys start to excrete the anesthetic drugs. So the patient's blood pressure comes back to the normal. So from 100, the patient blood pressure comes to 120. So if there is a rise in the blood pressure, there will be increased pulsatility of the blood vessel. So you have tied the blood vessel and there is increased pulsatility, then the suture which you applied will start to move distally. So there is a contraction relaxation of the blood vessel. So what the you have tied the suture, no? So if there is contraction relaxation, the suture will become loose on every contraction and starts to get displaced to the distal part. So at one point there will be slip of the ligature. Instead of all this, you just remember the reactionary hemorrhage will occur within 24 to 48 hours, and it is mainly due to the slipping of the ligature. So this is all about reactionary hemorrhage. Next is secondary hemorrhage. So we have discussed about primary, next is reactionary, and other is secondary. Secondary usually occurs at 5 to 7 days. The most common cause being the infection, sepsis. Infections, the secondary hemorrhage is due to the infections, usually occurs at 5 to 7 days. These are the most common complication. Hemorrhage, anywhere, like in shock, anywhere in general surgery, if they ask you hemorrhage, these are the three types of hemorrhages. One is primary, reactionary, and secondary. This is the most common complication in parotid surgery. The next is, as you all know, that you wanted to take off the superficial lobe. So superficial lobe and deep lobe. So what are the important structures there? There is a facial. Superficially, you have the facial nerve. So any injury to the facial nerves can lead to the facial nerve palsy. This is also one of the important complications, injury to the facial nerves. So any other complication, the one more very important question asked in every alternate NEET exams is like, what is Frei's syndrome? So Frei's syndrome, F-R-E-Y-S, Frei's syndrome or gustatory sweating. So what happens? You just remember Frei's syndrome, F-A-T, fat, Frei's syndrome. A-T is nothing but auriculotemporal. See, for any salivary glands, whether you take parotid gland or submandibular gland or sublingual gland, it secretes saliva. This secretion of the saliva is mediated by the parasympathetic nerves. Parasympathetic nerves is you just call it as secretomotor fibers. So whenever you see the food, you get saliva. This is mediated by the parasympathetic nerves supplying the parotid, submandibular, sublingual. So when you are doing a surgery, when you are removing out the parotid gland, you are more prone to injure the auriculotemporal nerve. So branches of the auriculotemporal nerve, which is a parasympathetic nerve. So usually it is supposed to supply the parotid gland and mediate the secretions, salivary secretions. During surgery, if you injure the auriculotemporal nerve branches, so what happens? This injured part of the nerves try to regenerate and try to synapse with the sympathetic fibers. Usually, the sympathetic fibers in the region of parotid, it supplies the skin and sweat glands. So what happens? See, the general thing. What happens here is there is a cross linkage between the parasympathetic and sympathetic. Parasympathetic is parasympathetic fibers is auriculotemporal. So these auriculotemporal synapses with the sympathetic. So whenever after postoperative superficial parotidectomy, if the patient starts to eat something, this auriculotemporal nerve, instead of supplying to the parotid gland, it supplies to the skin. So there will be sweating in the surgical site. So where we have performed the surgery, there will be sweating. This is called as gustatory sweating, the other name for Frei's syndrome. This is a very important topic. Frei's syndrome, the most common, this is one of the important, not the most common, it is a complication of superficial parotidectomy, wherein you injure the auriculotemporal nerve and there is a cross linkage between the parasympathetic and sympathetic fibers. So you just remember Frei's auriculotemporal, FAT, Frei's syndrome, injury to the auriculotemporal nerve. So apart from the facial nerves, you can also injure the marginal mandibular nerve. So if the marginal mandibular nerve is injured, there will be drooping of the mandible. So these are the most common complications regarding the surgery, parotid surgery. So next we'll discuss about ranula. So ranula, what do you mean by ranula? Ranula is nothing but it's a frog belly. Rana tigris. You have heard the botanical zoological name of frog, Rana tigris. So ranula is nothing but the belly of a frog. It is nothing but the mucus extravasation cyst. Just a moment. So So this is what we call it as a ranula. It resembles like a frog's belly. So it is nothing. See, ranula is a question. So it is a mucus extravasation cyst. There are two types of cysts. One it can be mucus extravasation, mucus retention cyst. Both are common in oral cavity. But if they ask you per se what is ranula, it is a mucus extravasation cyst. It is usually located in the floor of the mouth on either side of the frenulum, usually involving the sublingual gland. So it can present as a swelling in the oral cavity. There is a variant of ranula, plunging ranula. We call it as a plunging ranula, wherein both the lobes of the sublingual gland is involved. So it can present as a neck swelling as well as oral cavity swelling. So a point of note is here, ranula is an mucus extravasation cyst, whereas plunging ranula is an mucus retention cyst. Just remember, plunging ranula is a mucus retention cyst, whereas ranula per se is mucus extravasation cyst. For this type of cyst, usually the treatment is excision of the cyst, or also if the excision is not given in the option, you can go for marsupialization. Marsupialization is just you cut open the swelling, you just suture the end of the cyst wall with the surrounding structures, so that the fluid in the cyst continuously gets collected in the oral cavity and absorbed through the lymphatics. One is excision, or else you go for marsupialization. If both are given, the best option should be excision. So this is ranula, one of the differential diagnosis for oral cavity swellings. And next thing we shall discuss about this is also this topic is well known to you, I think. So this is also frequently asked question in the NEET exam. So here the arrow mark pointed. See, what is this? So it is nothing but the Staphny bone cyst. I think you are aware of this. Yes, excision along with the gland. So this pic shows. So what is it actually? So there is an radiolucent area here in the lower jaw. So it is nothing but the Staphny bone cyst. It is an ectopic salivary gland. The most common site is of ectopic salivary gland is the lower jaw. So this is also an important question. They'll be frequently asking this question. And, so apart from this, we'll discuss some of the benign salivary gland tumors. So benign salivary gland tumors, apart from pleomorphic adenoma, are Warthin's tumor. So Warthin's tumor, the points to remember regarding the Warthin's tumor is it exclusively arises from the parotid, whereas pleomorphic adenoma can arise from any of the major salivary glands, but Warthin's tumor exclusively arises from the parotid gland. It is usually seen in chronic smokers. In males, male predisposition will be there, and usually in males also, if the patient is chronic smoker, then the chances of Warthin's tumor will be more. So Warthin's tumor is exclusively seen in the parotid gland, and it usually involves the superficial lobe of the parotid. Usually seen in males who are chronic smokers, greater than 30 years of age. Warthin's tumor. So for this also you do an superficial parotidectomy. An important MCQ related to this Warthin's tumor is, this is the only salivary gland tumor which shows hot spot on treatment of ranula is, one is excision. If excision is not there, then you go for marsupialization. Marsupialization. So So where were we? Warthin's tumor. The important MCQ related to the Warthin's tumor is it shows hot spot on technetium-99. So technetium-99 is a radioactive material. So usually in general, where do you give radioactive iodine and technetium-99? So to identify which cells are active, or so in thyroid you will be giving radioactive iodine 123. So as to identify which part of the thyroid gland is active. So usually you'll be doing in hyperthyroidism. Same is the case in salivary gland tumors. So if you give technetium-99 to a salivary gland tumor, if the uptake is more, it presents as an hotspot. The question is the only salivary gland tumor which shows hotspot on technetium-99 is Warthin's tumor. This is also a question. Just remember, this is also a question. So Warthin's tumor is, see, pleomorphic adenoma, the most common site being parotid tumor. It can also occur in any of the salivary glands. But Warthin's tumor, it exclusively occurs in the parotid gland. So usually seen in males, chronic smokers greater than 60 years. Typical characteristic finding in Warthin's tumor is it shows hotspot on technetium-99 scan. The treatment is superficial parotidectomy. And also for revision, superficial parotidectomy, the incision taken is lazy S incision or cis trunk incision. So Warthin's tumor. So after this Warthin's tumor, you'll be discussing about adenoid cystic carcinoma. See, if the question comes as the most common malignant tumor of parotid gland or salivary gland, so it should be mucoepidermoid cancer, mucoepidermoid carcinoma. This should be your answer. If the same question comes as the most common malignant tumor of sublingual, submandibular, or minor salivary glands, so the most common malignant tumor arising from the sublingual, submandibular, and minor salivary glands is adenoid cystic carcinoma. In general is mucoepidermoid carcinoma. But if they ask specifically about submandibular, sublingual, or minor salivary glands, it should be adenoid cystic carcinoma. This should be remembered. This is also an important bit. So apart from all these things, there are important questions like parotitis. So parotitis, parotid abscess. So parotid abscess is also an important topic for your exam point of view. See, abscess anywhere in the body should be incised and drained. This is the general rule of surgery. So anywhere in the body you get an abscess, the treatment of choice, anywhere you get an abscess, the treatment of choice is incision and drainage, IND. We call it as IND, incision and drainage. In parotid abscess also, the treatment is incision and drainage. The incision and drainage, here the question is, what is the incision taken for parotid abscess? So this pleomorphic adenoma, it is cis trunk or lazy S incision. For parotid abscess, it is modified Blair's incision. Blair's incision, BLAIRS, Blair's incision. This is also very important question. One more question regarding parotid abscess is the most common predisposing factors for parotid abscess. It is usually old age, malnourishment, and dehydration. These are the three risk factors for parotid abscess. Just remember. One more important topic regarding salivary glands are this silolithiasis. So silolithiasis is nothing but the stones in the salivary glands. The most common gland to have stones among all the salivary glands is, it is not parotid, it is submandibular gland. So why submandibular gland? So there are a few reasons behind this. So salivary glands is located in the floor of the mouth, and the drainage of the cell. And one more question, the draining duct of parotid. What is the draining duct of parotid? It is Stensen's duct. The draining duct of parotid gland is Stensen's duct. The draining duct of Blair's incision. Just a minute now. The incision given for parotid abscess is Blair's incision. So silolithiasis. The silolithiasis, the most common gland to get to have more prone to get stones is submandibular. Submandibular gland. The location of the gland says it is located in the floor of the mouth, and the draining duct of submandibular gland is Wharton's duct. So the draining duct of parotid is Stensen's duct. Then the draining duct of submandibular gland is Wharton's duct. So Wharton's duct has typical property of anti-gravity drainage. So it goes against the gravity to express its secretions into the oral cavity. So this is one point, anti-gravity drainage, and the secretions. The secretions of the submandibular gland is predominantly mucus secretions. So mucus secretions try to get is more prone to undergo stasis. So because of its anti-gravity drainage and the mucus secretions, the submandibular gland is more prone to have stones. So this is also one more important question. So silolithiasis is more common in parotid, submandibular, sublingual, minor salivary glands. Your answer should be submandibular glands because of its anti-gravity drainage and predominantly mucus secretions. Just remember this. So submandibular, the draining duct of parotid is Stensen's duct. The draining duct of submandibular is Wharton's duct, and the draining duct of sublingual is Bartholin's or duct of Rivinus. These are the three important things. And the next question, how many minor salivary glands are there in the body? So this is also like NEET has this thing of they're very passionate about this thing, numericals. So they'll give you as options as 600, 800, 1200, 1800. So your answer should be, it is approximately 800 minor salivary glands, and most of them are located at the hard palate. Than the soft palate, most of them are located in the hard palate. Just remember. So major salivary glands, minor salivary glands. The major salivary glands usually tend to have benign tumors, whereas minor salivary glands, 80 to 90% tend to have 80 to 90. Nazia, I'll be telling that. So iodine 131 will be used in thyroid. So after we complete this, salivary glands will go into thyroid. Then we'll discuss there. So major minor salivary glands. The most common tumors of the major salivary glands are predominantly benign. Whereas if they ask you most common tumor of minor salivary glands, it's always malignancy. And as we all discussed, the most common malignant tumor in minor salivary glands is adenoid cystic carcinoma. So this differentiation you should be able to mark it. So the major salivary glands, the most common tumors are benign, whereas in minor salivary glands, the most common will be malignant tumors. So I think this covers important topics in salivary glands. So the important questions we got this NEET questions as which of the following salivary gland tumors shows hotspot and technetium 99 hotspot. So the answer is Wharton's tumor. So this you should remember. So next we'll jump on to we'll discuss this thing in thyroid. Thyroid hot spots and cold spots is very important in thyroid. I'll discuss the next topic. What we are discussing is thyroid. So thyroid is also a very favorite topic for general surgeons. So they'll be asking a lot of questions in thyroid. So thyroid is an endocrine gland. So I'll give a synopsis of thyroid. Then we'll go into the questions. So Thyroid is an endocrine gland situated in front of the neck in the anterior triangle. So, and it is located in the anterior triangle in front of the neck, extending from the C5 to T1. So it consists of two lobes joined by an isthmus. So they'll be asking you in the exam, like a 25-year-old female patient came with a chief complaint of swelling in front of the neck that moves on deglutition. So as soon as you see the word like it moves on deglutition, so your diagnosis should be go in favor of thyroid swellings, because it is a typical characteristic finding in thyroid swellings. All the thyroid swellings moves up with deglutition. So the next question comes is thyroid is enclosed in what? So thyroid is, see, the deep cervical fascia of the neck. So the fascia of the neck, the deep cervical fascia of the neck is divided into three. One is investing layer, other is pretracheal and prevertebral. These are the three layers of the deep cervical fascia. So thyroid is, see, the parotid is enclosed in investing layer, whereas the thyroid is enclosed in pretracheal fascia. It is, thyroid gland is enclosed in the pretracheal fascia, and the superior attachment of the pretracheal fascia is to the hyoid bone. So when during deglutition, during deglutition, the larynx is lifted up by the inferior constrictor muscles. So this larynx is attached to the thyroid by an Berry's ligament. This is also a question mark. Berry's, Berrys, Berry's ligament. So Berry's ligament is nothing but the condensation of the pretracheal fascia, which attaches to the larynx. So during deglutition, if the patient performs the deglutition, the inferior constrictor muscles of the neck pushes up the larynx. So if the larynx is pushed up, obviously the thyroid is also getting pushed up because of the Berry's ligament. The question here is, thyroid moves up with deglutition because of Berry's ligament. Answer should be Berry's ligament. If the question comes as Berry's ligament is a condensation of, it's a condensation of pretracheal fascia. So any clinical question, if they ask you in the exam, if you find anywhere like the swelling is moving up with deglutition, it should be thyroid swelling. So I'll just put a question for you. So if this is the question, this is asked in AIMS 2017 NEET paper, UG exam, MD/MS entrance exam. A 24-year-old, yes, very good. A 24-year-old patient presented with a history of neck swelling which moves with deglutition. It is A. So here there is no thyroid swelling. If the option is given as, if the option C is given as ectopic thyroid gland, so what will you mark? So because of its location, first looking at the diagram. So first thing what you have to see, if the clinical question comes to you, you just locate the swelling. Is it a midline swelling? So it's a midline swelling. It is not located in the region of thyroid. Thyroid is just inferior to this swelling. It is just located in the vicinity of the hyoid bone, and it is a midline swelling. So this should be thyroglossal cyst. If the question is given as, if the option C is given as hygroma, if the option C is given as ectopic thyroid gland, the question automatically gets changed as the swelling is moving with protrusion of the tongue. The point to be stressed is thyroglossal cyst moves with protrusion of the tongue, whereas thyroid gland swelling does not move with protrusion of the tongue. See, both the thyroglossal cyst and the thyroid gland moves up with deglutition. But the only difference between thyroglossal cyst and the thyroid gland swelling is thyroglossal cyst moves with protrusion of the tongue, whereas thyroid gland does not move with protrusion of the tongue. So here in this diagram, the swelling, it is located in the vicinity of the hyoid bone. So usually it is located to the left of the hyoid bone. Midline, usually to the left of the hyoid bone. So this should be remembered. This is an important question. So the question is, so we are discussing about Berry's ligament. Berry's ligament is nothing but the condensation of the pretracheal fascia. This thyroid lobe. So again, the anatomy is also very important in the exam point of view. So the thyroid is supplied by blood vessels. So some tricky questions will be there. I'll just explain you what is it. Thyroid is supplied by the superior thyroid artery and inferior. Yes, it's not superficial. Superior thyroid artery, superior thyroid artery, inferior thyroid artery, and thyroidema artery. Yeah. Superior thyroid artery, inferior thyroid artery, thyroidema artery. These are the three main branches of arterial branches supplying the thyroid gland. The main venous branches is, so superior thyroid artery is accompanied by superior thyroid vein. Inferior thyroid artery is accompanied by the inferior thyroid vein. The most important MCQ asked every alternate year is, the first vessel to be ligated in thyroidectomy is, anyone in the chat box? So the first vessel to be, see, I have mentioned you the arteries and the veins, no? So at least say me whether it is arteries or whether it is vein, which is first to be ligated. Anyone in the chat box? Yes, good. Vein. It is vein. Which vein?
Internal jugular vein, sir.
No, ma. It is, see, the venous drainage of thyroid. Yeah, let me explain you. The venous drainage of thyroid is superior thyroid vein, inferior thyroid vein, and the middle thyroid vein. See, always don't ever forget this. It's not internal jugular vein. If you ligate internal jugular vein, the facial, the total head goes into congestion. Facial congestion will be there. So you should never ligate the IJV, internal jugular vein. So the first vessel, the first and the important vessel to be ligated in thyroidectomy is middle thyroid vein. Just remember, don't forget, ma. Till you write your exam, don't forget this. The first vessel to be ligated is middle thyroid vein. Why it is important, I'll tell you. So this is the only single vein. So it is not accompanied by the artery. Usually superior thyroid artery and superior thyroid vein comes in pair, and inferior thyroid artery and inferior thyroid vein comes in pair, and the middle thyroid vein is a bachelor vein. It is a single vein. It drains the middle lobe of the thyroid. It directly drains into the IJV. So why it is important? Because during dissection, when you try to remove the gland, the middle thyroid vein is really short. It's very short and stout, and it does not have any valves. So if you try to manipulate the thyroid gland, so chances that you are going to injure the vein will be more. So the most common vein is middle thyroid vein. So because you have lengthy inferior thyroid vein and lengthy superior thyroid vein, relatively middle thyroid vein is more prone to get ruptured. As you all know that venous system does not have tunica media. Tunica media is nothing but the muscle layer is deficient in venous system. You all know that. So that is the reason why you get a thick artery wall and a poor vein wall. So vein wall is very fragile. Even if you give small pressure on it, it can tear off. So among these three vessels, middle thyroid vein is short and stout and more prone to get injured. So while doing thyroidectomy, while doing a thyroidectomy, if you try to injure the middle thyroid vein, there will be lots of bleeding in the intraop. So the venous bleed will be more. You cannot identify from where the bleeding is coming because of Seema. One thing I just wanted to tell is, see, this IJV system with the middle thyroid vein does not have valves. Usually the unidirectional flow of the blood in the veins is maintained by the valves. But in middle thyroid vein and internal jugular venous system, IJV, internal jugular venous system, you don't have valves. It is a valveless system. So anywhere if you try to injure, if the middle thyroid vein is ruptured, the air can enter into the IJV. It can lead into air embolism. This is also an important question mark. So middle thyroid vein, if you injure the middle thyroid vein, the patient can present with air embolism. And also the most common complication of middle thyroid vein injury rupture is, say, in order to clamp the vessel, you put your instruments in the, you try to secure the bleeding. So in this due process, there are high chances that you are going to injure the recurrent laryngeal nerve. The next question is, the recurrent laryngeal nerve and the middle thyroid vein will be in close proximity. So most common is recurrent laryngeal nerve injury, and the most dreadful complication of middle thyroid vein rupture is air embolism. These 2 points you have to remember, ma. Recurrent laryngeal nerve is the most common nerve to get injured, and the most dreadful complication is air embolism. So superior thyroid artery, inferior thyroid artery, thyroidema artery, these are the three arterial branches supplying blood supply to the thyroid. So three venous is superior thyroid vein, inferior thyroid vein, middle thyroid vein. Remember about middle thyroid vein. Don't forget about middle thyroid vein. So if they ask you Cocker's vein is seen in. So apart from this, if they ask you Cocker's vein is also a draining vessel of lower lobe of the thyroid. It is not present in all the patients. In 10 to 15% of the patients, the lower lobe of the thyroid is drained by a named vessel, named vein. It is called as Cocker's vein. So if they ask in brief, so which of the following is not supplied by not a venous drainage for thyroid? So they give you all the 4 options, like they give superior thyroid artery, inferior thyroid artery, superior thyroid vein, inferior thyroid vein, Cocker's vein, and they give you any other vein, Halsted vein. Yes, Cocker's vein. 4th option is Halsted vein. You just you need to be sure that there is also a Cocker's vein draining the lower lobe of the thyroid. Just remember, ma. So coming to the lymphatic drainage, what is the lymphatic drainage? This is also an important question, ma. Lymphatic drainage of thyroid. Can anyone type in the chat box? So what is the primary draining lymph node for thyroid? Not upper deep cervical, ma. Any other options? Any other answer? So at this point, I'll try to explain you about the levels of the lymph nodes. See, this is also very important. My next swellings will be asked. Yes, ma. Very good. It is pretracheal, ma. Pretracheal level 6. Pretracheal and prelaryngeal lymph nodes, also called as delphin lymph nodes, ma. Pretracheal or prelaryngeal lymph nodes is the primary draining lymph nodes of the thyroid gland. So coming to the levels of the lymph nodes, very important. So we have level 1 to level 7. Level 1 is again divided into level 1A and level 1B. Level 1A is submental. I'll just keep on telling. Level 1A is submental. Good. Level 1B is submandibular. Level 2 is upper deep cervical, middle cervical, lower, or upper jugular, middle jugular, lower jugular. These are the 3. 2, 3, 4. 2 is upper jugular, 3 is middle jugular, 4 is lower jugular. Then 5 is, what is level 5? Level 5 is posterior. So posterior group of the lymph nodes in the posterior triangle. The lymph nodes in the posterior triangle comprises of the level 5 lymph nodes. What is level 6? As we all discussed, as you all told, it is pretracheal and prelaryngeal. So what is level 7 then? Level 7. Yeah, level 6 is central compartment. Yes, upper mediastinal. So upper mediastinal is level 7. So I'll ask you a question. If the lymph node is located supraclavicular, if there is enlargement of the supraclavicular lymph nodes, then to which level it belongs to? This is also a question mark. Anyone in the chat box? If the patient is having a supraclavicular lymph node, just supraclavicular is nothing but just above the clavicle. If you find any lymph node just above the clavicle, so which level does it belong? This is also an important question. This is also asked in AIMS. Yes, it is level 5. Just remember, so the it's not 7, it's 5. It's 5. It belongs to posterior triangle. For this thing, you have to remember what are the boundaries of the posterior triangle. So what are the boundaries of the posterior triangle? Anteriorly, it is formed by the posterior part of the sternocleidomastoid. Anteriorly, yes. Anteriorly, it is formed by the posterior part of the sternocleidomastoid. Posteriorly, it is formed by the anterior border of the trapezius muscle. So, on the base is formed by the clavicle. So, the base is formed by the clavicle. The anterior border is formed by the posterior border of the sternocleidomastoid, and the posterior border is formed by the anterior border of the trapezius. So, any lymph nodal swelling above the clavicle comes under posterior triangle. Posterior triangle lymph nodes is level 5. This is also a tricky question. You just need to answer this. So here you have discussed about the levels of the lymph nodes, and also the first vessel to be ligated in thyroid surgery. The important vessel is middle thyroid vein. So we have discussed about the lymphatic drainage. So they may be asking about the clinical questions. So I'll just share a screenshot for you. Answer this question for me. So I want the diagnosis. If the question is asked like this in your exam, what will you mark? A. Any other answers? A. Still? Anyone? A. Okay. Anyone? Any other answers? B. Okay. So see, what is this diagnosis called as? So forget about the options. What is this actually? What is this spotter? What do you call this condition? It is pretibial myxedema. This clinical spotter is, it's not myxedema, it is pretibial myxedema. Pretibial myxedema, where it is seen? Okay, see, there are two clinical symptoms of two different clinical symptoms of hypo and hyper. Yes, remember, hypothyroidism, hyperthyroidism. So yeah, pretibial myxedema is seen in hyperthyroidism. So I just wanted to tell you. So what are the symptoms of hypothyroidism? So I'll just tell you in detail. What are the symptoms of hypothyroidism? Hypothyroidism symptoms is weight gain, loss of hair, edema, myxedema. So usually if myxedema is there, the etiology should be hypothyroidism. If it is pretibial myxedema, then it goes into hyperthyroidism. So myxedema, if you find only myxedema in the question, then you should invariably put hypothyroidism. If it is mentioned specifically like pretibial myxedema, if it is mentioned as pretibial myxedema, then you should mark the answer as hyperthyroidism. Just remember. So cold intolerance is seen in hypothyroidism. Heat intolerance is seen in hyper. So the point to differentiate is, see, the primary, okay, yeah, good. The See, the primary function of the thyroid gland is it secretes. It's an endocrine gland, no ma. It is an endocrine gland secreting T3 and T4. T3 and T4. T4 is thyroxine. T3 is triiodothyronine. So these two hormones are responsible for the basic metabolic rate, BMR. So in any part of the body, if there is a need for heat production, so it is primarily due to the T3 and T4 hormones. In the case of hypothyroidism, already there is a deficient amount of T3 and T4. If the patient is exposed to cold, so normal mechanism is if the patient is exposed to cold, the body tries to generate heat. In a patient of hypothyroidism, there is deficient T3 and T4, so there is no production of the heat. So patient tries to stay away from the cold. This is called as cold intolerance. Hypothyroidism, cold intolerance. These are the simple questions. You should never mark it wrong. So cold intolerance, it is hypothyroidism. Heat intolerance, it is hyperthyroidism. Heat intolerance is nothing but the patient is hyperthyroidism. He is getting an excess of T3 and T4. There is increased warmthness in the body. So if you try to put the patient in the warmthness, the patient feels uncomfortable there. So he tries to stay away from the heat. It is heat intolerance. These are the two important things. And the most common gynecological or menstrual abnormality in hypothyroidism is most common menstrual abnormality in hypothyroidism. Anyone in the chat box? Yeah, it is menorrhagia. Menorrhagia. It's just remember it's menorrhagia. It's not hypo or it's not A. It's menorrhagia, excessive bleed. This is also an important question mark. The most common menstrual abnormality in hypothyroidism is menorrhagia. And the most common menstrual abnormality in hyperthyroidism is oligomenorrhea. So here menorrhagia, here oligomenorrhea. Yeah, oligomenorrhea. So these are all related to, so diarrhea is seen in hyper or hypo? Diarrhea is seen in hyperthyroidism, whereas constipation is seen in hypothyroidism. And one point to be remembered is, so there is a specific pattern of hair loss in hypothyroidism. Apart from the scalp hair, there is also loss of eyebrow hair, eyebrow hair loss. So there is a specific pattern. So if there is lateral loss of the eyebrows, we call it as a madarosis. Lateral loss of the eyebrows is typically seen in hypothyroidism. Just remember, hypothyroidism, there will be loss of hair. Excuse me, just a minute. Sorry, sorry for the interruption. Where were we discussing? Where were we? Yes, good. So eyebrows, there is a typical loss of eyebrows. If the lateral part of the eyebrows is lost, it is usually typically seen in hypothyroidism. My question is medial loss of eyebrows. Yeah, medial loss of eyebrows is seen in which of the following condition? Which condition? Leprosy. Very good. So it is leprosy. Medial loss of eyebrows are seen in leprosy. Lateral loss is seen in hypothyroidism. So my next question is, this is also an important question. It can be asked both in medicine or surgery. The earliest and the first characteristic clinical sign to be elicited in hypothyroidism. I think we have discussed this in the class I've taken the past. Yes. See, there will be delayed relaxation phase of an reflex arc. There will be, so you'll be doing the knee jerks and all, no? Knee jerks, ankle jerks, the reflex this thing. So there will be there are two phases in this. So one is contraction phase and the relaxation phase. So the contraction phase will be normal in hypothyroidism patients, but the relaxation phase, the muscle comes to the relaxation phase in a very slow and phased manner. So this is a typical characteristic sign and the first sign to be elicited in hypothyroidism. This also you should be able to remember, ma'am. Important question. So these are the clinical symptoms and signs in thyroid, ma'am. So apart from this, one more important question is, what is the function of cricothyroid muscle? What is the function of cricothyroid muscle? Anyone? Cricothyroid is, where do you get cricothyroid muscle? Yeah, it is the intrinsic muscles of the larynx. So intrinsic muscles of one of the intrinsic muscles of the larynx, which is a tensor of the vocal cord. So cricothyroid muscle is supplied by, this is also, yes, only tensor. It maintains the pitch of the voice. The cricothyroid muscle is supplied by, anyone? Cricothyroid muscle is supplied by? Yes, it is external laryngeal nerve. Ma, this is also very important topic, ma. All the, see, just remember, all the intrinsic muscles of the larynx, all the intrinsic muscles of the larynx are supplied by what? Transverse arytenoids. You have all these intrinsic muscles of the larynx. No, this, all the intrinsic muscles of the larynx are supplied by recurrent laryngeal. Yes, very good. Supplied by recurrent laryngeal nerve, except cricothyroid, which is supplied by external laryngeal nerve. External laryngeal nerve is a branch of superior laryngeal nerve. Superior laryngeal nerve is a branch of vagus. Very good. So vagus, superior laryngeal nerve, external, internal. So external supplies the cricothyroid. So what about internal? So external supplies the cricothyroid. It is sensory supply above the vocal cord, specifically above the vocal cord. So if the question is asked, the sensory supply below the vocal cord is so your answer should be recurrent laryngeal nerve. So in brief, I'll just tell you all the intrinsic muscles of the larynx are supplied by the recurrent laryngeal nerve, except cricothyroid. Cricothyroid, which is supplied by the external branch of the superior laryngeal nerve. The function of the cricothyroid is, it is the tensor of the vocal cord. It maintains the pitch of the voice. This is also a question. This is also a question. It maintains the pitch. So the internal branch of the superior laryngeal nerve is a sensory supply above the vocal cords, whereas the sensory supply below the vocal cords is primarily by recurrent laryngeal nerve. This concludes about the sensory supply and all nerve supply regarding this thing. And one more thing. So this is also one more question. See, the superior thyroid artery and the inferior thyroid artery should be ligated close to the gland. So I think during your final year exams, they'll be asking question clinically. So if you want to perform a thyroidectomy, you have to ligate the vessels first. So the ligation of the vessels also should be done carefully. Sensory supply part. The sensory supply above the vocal cords is primarily by internal branch of the superior laryngeal nerve, whereas
the sensory supply below the vocal cords is primarily by the recurrent laryngeal nerve. So, if at all you are going to remember at only one nerve in thyroid, so it should be unanimously recurrent laryngeal nerve. Recurrent laryngeal nerve plays a very important role in thyroid surgery because the post-operative complications like hoarseness of the voice and everything is related to the recurrent laryngeal nerve injuries, and the most common nerve to get injured in thyroidectomy is recurrent laryngeal nerve. So, and the dreadful complication is also seen if you injure the recurrent laryngeal nerve. The vocal cords will go into a cadaveric position and the patient can have aspiration. So utmost care should be taken not to injure the recurrent laryngeal nerve. My question is, during ligation of the pedicles, ligation of the vessels, both superior thyroid artery and the inferior thyroid artery both should be ligated close to the gland. It's not, say previously it was like superior thyroid artery should be ligated close to the gland. Inferior, previously it was there like this. Superior thyroid artery should be ligated close to the gland. Inferior away from the gland. Previously it was there. The recent editions of Bailey and every other surgical books says that both the superior thyroid artery and the inferior thyroid artery should be ligated close to the gland. Why? Because the inferior thyroid artery, if you are going to ligate away from the gland, then you are going to sacrifice the blood supply to the parathyroid glands. Thyroid is not alone, it has along with it has parathyroid glands. We have 4 parathyroid glands, right? So if you are going to ligate the inferior thyroid artery away from the gland, then you are going to sacrifice the blood supply to the parathyroid also. That is the reason why it has been totally changed in all the books that you should ligate both the vessels close to the gland. And what are the different surgeries? So we'll discuss about this thing. We'll discuss about this these surgeries. So there are different named surgeries, very important for you. What is hemithyroidectomy? What is hemithyroidectomy, subtotal thyroidectomy, near total thyroidectomy, and total thyroidectomy? These are the 4 questions repeatedly asked in clinical surgeries. So, what is hemi? So, whether it is one lobe or whether it is one lobe plus gland, one lobe plus isthmus. So, it is. See, if they ask you what is hemithyroidectomy, it should always include the whole of the isthmus. One lobe with isthmus. So it should not. It is not half isthmus and one lobe. It is total isthmus and one lobe. It is called as hemithyroidectomy. So what is subtotal? What is subtotal thyroidectomy? So you retain 1/8 of a gland on the either side. So 1/8 of a gland on the either side, not on one side, on the either side. On the either side at the tracheoesophageal groove. See, the lobes of the isthmus, the lobes of the thyroid lies at the tracheoesophageal groove. So while doing a subtotal thyroidectomy, the rule is you have to retain the 1/8 of the gland on the either side. On right and the left lobes, you just retain 1/8 of the gland. It is called as subtotal. And the recent question, even in the super specialty point of view, also they have asked us the question like Hartley-Dunhill procedure is done. See, I just wanted to tell you, this is also an important question. The other, yes, ma'am, very good. The other name for near total thyroidectomy is Hartley-Dunhill procedure. This you have to remember. Hartley. You are all aware of that procedure name. No? Hello, is it clear, ma'am? Hello, am I audible? Yeah. The other name for near total thyroidectomy is Hartley-Dunhill procedure, wherein you remove one entire lobe, one entire isthmus, and the so if you are going to remove the, see, if the pathology is in the right lobe of the thyroid, you are going to remove the entire right lobe, the isthmus, and the entire left lobe, retaining 1/8 of a gland in the tracheoesophageal group. Whereas in subtotal, on the other side, you will be retaining 1/8 of a gland. Whereas in near total, you will be retaining only on one side. So it is also called as Hartley-Dunhill procedure. The next one is total thyroidectomy. Total thyroidectomy, wherein you entirely remove the parathyroid glands. This is the different surgeries. Say again, if they ask you the complications of thyroid surgery, the parotid and the thyroid both are the same. So, but here instead of you were discussing about the facial nerve, here we will be discussing about the recurrent laryngeal nerve. So the most common complication is, see, anywhere in surgery, the most common complication is hemorrhage. If you don't know the answer, directly put hemorrhage. So again, the hemorrhage is again here. They'll be asking you the primary hemorrhage, secondary hemorrhage, reactionary hemorrhage. One thing, say there is a very important clinical question regarding thyroid surgery. So, hello. So you are an intern in the hospital. So from my side, is there any disturbance from my side? I think I even switched off my fan also. Am I audible? Yeah. Okay, fine. Please let me know if my voice is a little bit disturbance to you. Like if there is any interruption in my voice, please tell me. One more clinical question, important clinical question usually asked in the exam is like you are being posted in the post-operative ward. The patient has been undergone this total thyroidectomy. The patient after 6 hours of surgery presented with dyspnea, shortness of breath. So on examination, you have been you have seen an swelling in the neck. What will you do? Yes, this is very good one. So this is a frequently asked question. So see, the most common complication in the immediate post-op is tension hematoma or wound hematoma. So wound hematoma or tension hematoma, wherein so there will be any slippage of the ligature. This blood. See, you are removing the thyroid gland. There is a dead space. So previously there was a thyroid gland. You remove the entire thyroid gland. There is a space over there. So any small blood, any bleeders, any small bleeding vessel, there will be accumulation of blood clot in the thyroid bed, compressing the trachea. So previously thyroid was there, now the blood clot is there. So this hematoma getting organized compresses on the trachea. So patient complains of shortness of breath. There will be dyspnea. So immediately what you have to do is you have to remove the sutures. There will be last option will be given as, so the suture should be removed and the bleeder should be identified. So this should be your answer. It should not like shift to the ICU, call to the surgeon. So this is not the thing. The first thing you have to do is remove the suture and identify it. Then you do the emergency thing. You have to shift the patient to the ICU, call to the surgeon. The first appropriate step should be you remove the sutures. This is also important question. So one more spotter for you. So what is this? So this is an resected specimen of thyroid. Okay. Yes, good. So yes, it's a very good. So the specimen is multinodular goiter. So you're able to differentiate, and there is multiple nodules over the left superior isthmus and all. So thyroid, as per se, doesn't look like this. If there are multiple nodules, we call it as an multinodular goiter. See, if the same thing is given, what is the treatment of choice for this condition? What will you answer? What will be your answer? Subtotal. Total. So previously it was subtotal. Now it has been changed to total. So any case of multinodular goiter. See, I just wanted to ask you a question. So what is the indication of surgery for multinodular goiter? Why is it required? The most dreadful complication of multinodular goiter is, or else my question is, long-standing goiter. Long-standing goiter can give rise to. This is also an important question for you. Carcinoma. Which carcinoma in specific? Malignancy. Good. Which malignancy? Which one? I think you all know that 4 types of malignancy in thyroid. It's not papillary, Pratisha. It's not medullary. It is follicular. See, just remember for FO, for long-standing goiters. For long-standing goiters, it can turn into follicular. So if the same question is asked as previous history of radiation, the most common thyroid malignancy to occur is, the most common thyroid malignancy to occur in previously irradiated patients is papillary. These two you have to differentiate. So papillary, there should be previous history of radiation, whereas follicular, it should be long-standing goiter. So multinodular goiter can turn into follicular malignancy, and also multinodular goiter can also get turned into secondary thyrotoxicosis. We have 2: primary thyrotoxicosis, secondary thyrotoxicosis. Primary thyrotoxicosis, you call it by the name of Graves' disease. Graves' disease, yes. Secondary thyrotoxicosis, usually the clinical point of difference between these two is in primary thyrotoxicosis. Before you are able to palpate the swelling, you will be getting signs of hyperthyroidism. Just remember, yeah, CNS and CVS. Clinically, I'm saying, look at the patient will be having more pronounced clinical symptoms than in thyroid swelling. So the symptoms and signs are more prominent than the swelling in primary thyrotoxicosis or Graves' disease, whereas the swelling appears first and then followed by the thyrotoxic symptoms, hyperthyroidism in secondary thyrotoxicosis. Just remember, the symptoms and signs are more pronounced than the swelling in primary, whereas in secondary, usually the swelling comes first, followed by hyperthyroidism feature. These two you should be able to remember, and the main important feature is CNS symptoms is most probably seen in primary or Graves' disease, whereas CVS symptoms, cardiovascular symptoms, are usually seen in secondary thyrotoxicosis. This is also an important thing. So very good, you have answered this question, and I'll be sharing one more question. You should be able to answer this also. What is this, ma'am? I want this answer. PBP. Yes. So I think you are all like well versed with the subject actually. To general surgery. This Dalrymple sign. So what do you call Dalrymple sign? In a normal term, what do you call? What do you see here? So Dalrymple sign is
There will be retraction of the upper eyelid.
It is lid retraction. It's not lid lag. Lid lag is von Graffis sign. Lid lag is von Graffis sign. Lid retraction is Dalrymple sign. Usually, you check your eyes, you cannot, you do not see your upper sclera. If the upper sclera is seen clearly, then it is called as lid retraction, also called as Dalrymple sign. So, what is Stellbox then? So you answered this question as Dalrymple sign. You need to know all the three options, no? Just remember, must tell. Yes for yes, staring look. Stelvar, staring. Right now I don't have. I'll show in the next class for sure. So Dalrymple sign is lid retraction. Stellbox is staring look. So what is Geoffroy?
When the patient looks up, then the on the forehead.
What, ma?
If the patient looks upward, then there will be absence of bridging on the forehead.
That's very good. So loss of forehead wrinkles. Loss of forehead wrinkles is nothing but Geoffroy sign. What is Mobius sign then?
Failure of convergence of eyeballs.
Yes, very good. Convergence of inability to converge. Yes, good. So these are the four important signs, ma. Geoffroy sign. So loss of wrinkles, Dalrymple, lid retraction, Mobius, loss of convergence, Stellwax, staring, and von Graffis is lid lag. Lid lag is nothing but the upper eyelid and the eyeball does not go in pace. So there is a lag between the movement of the eyeball and the upper eyelid. So this is called as von Graffis sign. These are the 5 important signs in hyperthyroidism. So what type of tremors do you get in hyperthyroidism? So apart from eye signs, you'll be having these tremors also. CNS manifestations are usually seen in primary hyperthyroidism. GTCS, it is tonic-clonic seizures, no ma. I'm just asking tremors, what type of tremors? Whether it is fine or coarse. It's fine tremors, ma. Fine tremors is seen in. So how will you demonstrate? If like you put a white paper over the, if you put a white paper over the dorsum of your outstretched palm. So you can see, you can able to differentiate the fine movements of the paper. So like this you can demonstrate, and also you can see the fasciculations in the tongue, movement of the tongue. So these are the two things where how you can see, like how you can elicit the tremors. One is tongue, other is outstretched hand, put a paper over the dorsum of the palm and demonstrate it. So I think one more clinical question I'll just ask you. What is this now? Yes, very good. So this was asked in the recent exam. Very good. So Pemberton sign. So are you all aware of this test, Pemberton sign? Venous congestion. Good. So ask the patient to lift the hands above the shoulder. So for what it is done, Pemberton sign. So Pemberton sign is positive in retrosternal goiter. Very good. So if there is on this maneuver, if there is facial congestion, then there is retrosternal extension of the goiter. So the goiter compresses the venous system, causing venous congestion. So what is Lahey's method then? So Lahey's method is used to see. You all told me like Pemberton sign is used for retrosternal goiter. So then what for Lahey's method? Lahey's test is done. Anyone? So then what for Kryles is done? So, okay, fine. Let me tell you. So Lahey's method, see the posterior medial aspect of the Kryles for nodules, good. So any thyroid nodules, small nodules can be picked up by Kryles test. So Kryles test wherein you put your thumb over the thyroid gland and ask the patient to perform deglutition. So if the patient is performing deglutition and the thyroid slides over your thumb. So if there is any nodules, then it can be appreciated by your thumb. For small nodules, Kryles test is done. Pemberton's for retrosternal extension. And Lahey's method is done for the thyroid lobes, the lateral lobe, the posterior medial. Sorry, the posterior lateral lobe of the thyroid is embedded in the tracheoesophageal groove. Hello. The posterior lateral part of the lobes of the thyroid is embedded in the tracheoesophageal groove. In Lahey's method, you try to push the thyroid to the one side. See, for example, if in this patient, if you are seeing if there is swelling in the left lobe of the thyroid gland, so you are going to push the left lobe to the left side by your right hand. So just remember, this is use it to like palpate the posterior lateral aspect of the thyroid gland. So by doing this maneuver, you'll try to bring the posterior lateral lobe of the thyroid out of the tracheoesophageal groove so that you can palpate with your other hand. Just remember posterior lateral aspect of the thyroid gland. You'll be doing the Lahey's test. For Pemberton's, it is retrosternal goiter, and for Kryles, you have nodules to identify the nodules. And one more slide I would like to share. What is the answer for this one? And what is this sign called as?
Cross-chest sign.
Yes. Yes, man. Trozier sign. So it is seen in hypocalcemia. Very good. Hypocalcemia. So this is also called as carpopedal spasm or Trozier sign. Carpopedal spasm. Yes, tetany. But to be precise, it should be carpopedal spasm. So it is usually one of the post-operative complication of thyroidectomy, total thyroidectomy. This is also an important question. See, in AIMS pattern, the NEET pattern, see this FMG exam, we have this FMG exam, foreign medical graduate exam, and this NEET UG exam. Everything they are asking clinically now. So they're putting questions like this and asking, so what is your diagnosis? What is this? So I think for you also they may be asking like this only. This is Trozier sign, also called as carpopedal spasm, usually seen due to the hypocalcemia, one of the complication after in the post-operative period of thyroidectomy. This you should be remembering. And what do you mean by Chevstok sign? Someone in the chat box has typed Chevstok sign. What do you mean by that? Chevstok sign is you tap on the nerve trunk, so if you tap twitching of the facial muscles on tapping over the facial nerve trunk. If you hit over the nerve, tapping, yes, facial muscles, there will be twitching of the facial muscles. Very good. So these two you should remember as a postoperative complications due to hypocalcemia. One is carpopedal spasm and is this thing, Chevstok sign. So complications. So we'll discuss briefly about this malignancies also, because malignancies also they've been asking. So there are 4 types of. I'll just tell in brief,
So malignancies, there are differentiated, medullary, undifferentiated. Differentiated cancers. Um, yes, it is also seen as an complication. See, hypocalcemia, it can be presented as either carpopedal spasm or Chevstokes sign, both. Any of it can be presented as any of these things like Chevstokes or carpopedal spasm. So where were we? We're discussing about malignancies, differentiated tumors. Differentiated tumors is papillary and follicular. Just remember, in papillary carcinoma of thyroid, it is the common thing is the previous history of radiation. And remember, P for prognosis, very good prognosis for papillary carcinoma. And P for Samoma bodies. So Samoma bodies are character. I think you have a subject of pathology in entrance exam also, no? Right? You have pathology. Yeah. So Samoma, what are Samoma bodies? Samoma bodies, nothing but the
tissue.
dystrophic calcification, in specific dystrophic deposits of calcium, specifically seen in papillary carcinoma. See, if you get a question on histopathology, Samoma bodies are identified. Which tumor? So you can without any hesitation you can put papillary. So it is seen in only few of these malignancies. One among them is papillary. Papillary prognosis good, and Samoma bodies, previous history of radiation, very good prognosis. Just remember this thing. And what about follicular? For follicular, it is long-standing goiter. In papillary, the spread of papillary carcinoma is through
Lymphatic spread.
Lymph node.
yes, very good, lymphatic spread. And the spread of follicular is
blood then.
follicular, it is blood. For this papillary, it is lymphatic. And medullary, what about medullary then?
Blood.
It's not only blood. So let me tell you, local invasion for anaplastic. Remember, local invasion for anaplastic, both lymphatics and blood by medullary. Papillary, only lymphatics, and follicular, only through blood. That is the reason why, if the patient is presenting with thyroid swelling and cervical lymph nodes, without with your clinical knowledge, you can directly say it can either be papillary or it can either be medullary, but not follicular, because it spreads through blood. So if the question is asked, the question follows like this: a 65-year-old male patient presented with bony pains, vertebral bony pains. On examination, there was an swelling in the anterior triangle of the neck. So there was a thyroid swelling. What is your diagnosis clinically? So among all the options, if the options will be given as papillary, follicular, medullary, and anaplastic. The point is bony pains with thyroid swellings. Which malignancy? Papillary, follicular, anaplastic, and medullary. What is it? It is follicular. It's not medullary, it's not papillary, it is follicular. Your first option should be follicular. You should mark follicular. Follicular tends to spread through blood, and the most common site being the vertebral bones. Vertebral bones and long bones, femur, skull, vertebrae, and femur. Bones, yes. So bony pains. See, the patient presents with bony pains. See, bony pains, if the patient is having tenderness in the bone with thyroid swelling, so your first First diagnosis should be follicular. You mark it as follicular. It's not medullary. Medullary comes second. If the option is given as papillary, follicular, anaplastic, medullary, go for follicular. It's not medullary. The the most common tumors of the thyroid is papillary and follicular. Medullary is relatively rare. It is a hereditary kind. So usually presents within 10 years. Medullary carcinoma. A 65-year-old male patient, you are talking about a 65-year-old male patient, the medullary carcinoma is excluded. So it is hereditary. Medullary is hereditary. You all know about MEN2 syndrome, MEN2A, MEN2B. So it comes below 10 years. So 65 years patient with bony pains, highly unlikely that you're dealing with medullary. It should always be follicular. Just remember, everything in the question is an important thing. Age is also important in thyroid. So mark it as follicular. Clear, everyone clear? Thyroid swelling with bony pains, follicular. So anaplastic, you have direct local spread, direct invasion. So patient presents with dyspnea, dysphagia. Directly it infiltrates into trachea. So which thyroid swelling along with the anaplastic, which so this is also one more question, which thyroid disease mimics anaplastic carcinoma? So I'll give, so less than 10 years. It is hereditary. Medullary carcinoma is hereditary. The most common presentation is below 1 year. It occurs in the families. So I was asking you about the question, no? So which benign condition of the thyroid mimics anaplastic carcinoma? I'll give you the options: Hashimoto's thyroiditis, viral thyroiditis, Riedl's thyroiditis, de Quervain's subtotal thyroiditis. Your answer? Hashimoto's. It's not Hashimoto's. The benign condition which mimics this thing is Riedl's. Very good. Riedl's thyroiditis. Riedels. Riedl's. Yes, this should be remembered. So in Riedl's thyroiditis, there will be fibrosis of the thyroid gland, which compresses over the trachea, same as seen in anaplastic. So this two small points regarding Hashimoto's thyroiditis. So what is Hashimoto's thyroiditis, Antibodies, autoimmune disease. It is an autoimmune disease. Very good. So antibodies to what? Which enzyme? This is also an important question, against which enzyme of thyroid gland is Hashimoto's most common? Not thyroglobulin, still. It is TPO. Good. Sunanya. TPO, thyroid peroxidase. 95% in 95% of the cases, the antibodies are directed against the thyroid peroxidase and enzyme. So the patient will be having initial. See, this is also an important question, In Hashimoto's thyroiditis, the patient will be having initial hyperthyroidism, then euthyroidism, then hypothyroidism. So there will be autoimmune. Just listen this carefully, there is autoimmune destruction of the thyroid glands. So thyroid follicular cells already has T3 and T4. So if already have T3 and T4, if the patient is if the antibodies are directed against these thyroid glands, so there will be expression, the excretion of this stored thyroid hormones into the blood. So patient will be having initial spike of hyperthyroidism, then followed by the hyperthyroidism state comes to the euthyroid state and then gradually goes into the hypothyroidism state. So the question is, all the three stages can be seen in Hashimoto's thyroiditis. This is also one of the important question mark. Initial presentation will be hyper, then patient comes to U, and then patient goes into hypothyroidism. So patient can have all the three in Hashimoto's thyroiditis, and it is an autoimmune disorder. The most common antibody directed against the thyroid peroxidase enzyme. So they should be remembered. I think most of the important questions I think I covered in thyroid. Let's take it. You want lunch break, ma? You want a break? Anyone? So how much time? Oh no. Let us take 5 to 10 minutes break, ma. I'll be back. I just wanted to cover some important topics, some trauma and all. I'll be back. 5 to 10 minutes.
Hi students, can I take the class tomorrow? The same time, 11 to 1. Uh, I'll be taking this trauma and all trauma ulcers wounds in a detailed way. So same as like any fee like any feedback or should you any specific topics you want in detail, or any you want more questions, or like this type of explanation is okay for you? Yeah, arterial venous trauma wounds, and one more thing, see surgical instruments and suture materials, will they be asking you in the exam? Okay, fine. So I'll try to complete it by tomorrow, 11 to 1. Yeah. Okay. Thank you students, thank you, bye. Yeah, sure, blood transfusion, right? Yes.